just okay. I think we can start in any case, even if people are still joining. Okay, so welcome everybody. This is the second round of European G1, but it's the first time we discuss clinical cases or clinical scenarios. So it's a kind of experiment, if you want. Indeed, you know that we are holding these meetings the first Friday of each month. One time is devoted to a paper or a presentation recently reported or published, and the other time we would like to discuss some clinical scenarios which may be somewhat typical but worth discussing. And we would like to do it with a probabilistic approach, so trying to make explicit the probabilities which we envisage. So again, this is an experiment, and so please provide us with any feedback about whether you feel that an approach like this may make sense. We will ask also you to vote during the presentation. So I share my screen. Okay. So we will talk about lung metastasis from adult soft tissue sarcoma. So this is the topic, which are, you know, very, very typical. We all, as sarcoma physicians, are used to having to make decisions. And so the first clinical scenario I would like to share with you is imagine you have a undifferentiated pleomorphic sarcoma, so a very typical and common adult soft tissue sarcoma. Imagine it's the first distant relapse, that the free interval was 1 year. There are just a couple of nodules, staging is negative. There was no previous chemotherapy. So my question is whether all of you would do surgery, or some of you would prefer chemotherapy only, so without surgery. And the second question will be, what do you believe about radiation therapy? So if, I mean, to which extent you believe that radiation therapy, for example, a stereotactic radiation therapy, could be the same as surgery or not. So just to start, I would like to ask you concerning the first probability here. So how would you rate the chances of cure with surgery of lung metastasis in this patient? You see 0, 10%, 20, 30, 40, 50, or more than 50. What? How would you vote? You should see on your screen the tool, the voting tool. So, Joanna, do you think we can see the...
Yes, I mean, at the moment, 12 people have answered. Do you wish to wait?
Okay, few people, so we can wait a little bit.
Mm-hmm. I think no one else wishes to answer, so I will just share the results.
Paolo, you're muted.
Okay. Okay. So, okay, the answers were quite, I mean, scattered between us. So, someone also that there are no chances of cure, and while some were quite optimistic, even 40–50%. Okay, I mean, it would be difficult to have an answer because clearly these questions are very open, and so any comment about this, the audience?
If I can,
Yeah.
I voted 10%, because probably the 1 year interval is not so much to hope for a higher probability, even if the number is pretty good. I mean, too odious. I wouldn't, which may answer to the second poll, give a different probability for radiation, at least in a medium interval, short to medium interval. Maybe some differences may be seen in a longer interval. So in that case,
okay, let's try to ask people so to vote about the second probability, about how much, how many chances of cure would you forecast for radiation only? So in comparison to. So please, if you can vote. Oh, Antonella, would you like to
Hi, I'm
say
here. I'm connecting from Sardinia, actually.
Okay.
And thank you very much for involving
Lucky you.
me in this very challenging job. As for radiation, I don't know if there is any radiation therapist connected, but as far as I know, at least in lung cancer, for small nodules, chances of complete responses with radiation therapy are almost overlapping with surgery. So I don't know if there is any radiation.
Yeah.
Hi.
Hi, Claudia. Yeah, I confirm your this one because I treat a lung patient, and in the early stage, in unfit patient for surgery, I think stereotactic radiation therapy is very similar in local control than surgery. So it's a very good chance for the patient.
So probably what we're lacking is a very long follow-up. But I mean,
yeah. But this synthesis is due to the fact that the patient I have a long follow-up for a lung patient treated with a stereotactic radiation treatment. So I can, it's a chance, it's not feasible for surgery.
So I mean,
sorry, Claudia, may I ask
please,
you?
Please.
Hi, Paolo. Hi. Sorry, may I ask you if you are talking about the primary tumor from lung, primary lung cancer, not or lung metastasis from?
No. I have I did a comparison between early stage lung cancer and metastases from sarcoma.
The concept is
the treatment is the same.
Yes,
so
if primary lung cancer
ablative.
it works, why not for lung metastasis? I mean, this is the assumption. Of course, it's an assumption, but I mean, we don't have so many data about this. So what do you think, Giacomo?
No, yeah, I think that the main difference is that here we are talking about a metastatic disease, And I think that in lung cancer, yeah, I don't know the data in lung cancer, I'm sorry for that, but we are talking about primary lung cancer. And in unfit patient, I know that in the early stage disease, we can cure patient with radiotherapy only. But here it's a different scenario, in my opinion, since we are faced with a metastatic disease.
Yeah, no, of course, but I mean, if technically speaking, the
Yeah.
effectiveness on the lesion is the same, I mean, you could assume that surgery may not be.
Yeah,
that
the
different.
radiation
So,
approach is a similar for surgery approach in case of local regional treatment. But
Yeah. As a matter of fact, we don't have any comparison for small and in size and few in number metastases comparing surgery with radiation therapy. That was what we were saying, Giacomo.
Yeah, of course. Okay. So no, because this is a decision which sometimes is made just on the basis of the surgical feasibility, you know. So there are some lesions which are more amenable to surgery, there are other lesions which are less. And so the question is, to which extent are we allowed to see radiation therapy as potentially as effective as surgery? And I understand from the people who are now joining that probably, I mean, several of them wouldn't make so much difference between surgery and radiation therapy, which is interesting, but clearly we lack data, certainly prospective data, but we lack also prospective studies also on surgery, you know, even if surgery of lung metastasis was first made in the 19th century, so many years ago. I see Lorenzo D'Ambrosio.
Hi, Paolo. Hi, all. I think that one potential difference between surgery and radiation, stereotactic radiation, is mainly related to the fact that you can have some unexpected finding at time of surgery of small nodules not detected by CT scan. So this is probably what can justify the small difference that is seen in other tumors also between stereotactic body radiation and surgery. But in my personal opinion, the effectiveness, the cytotoxic activity on the lung nodule itself is not that much different compared to new techniques with high dose of stereotactic radiation. So probably the difference might be on this side. And for a situation like this one, with a quite short disease-free interval, also this might be put, I think, in the decision-making process.
Yeah, by the way, many years ago, when we didn't have spiral CAT scan, the number of nodules, you know, that the surgeons found unexpectedly when they operated on the patients was quite high. So there were many nodules which were not seen on CAT scan. Now with spiral CAT scans, it's I mean, this number is clearly lower. And I mean, for example, at our institutions many years ago, we did systematically sternotomy just to explore both lungs and to rule out that there could be nodules which were not seen. Okay, any other comment on this, Salvatore?
Yes, always in this last regard. Apart from what you said, I think that in that case, if surgery found more nodules than what you expected on the CT scan, much likely it would not be more resolutive than radiation in any case, because in that sense it would mean the disease would have a
more spread then.
Yeah, more spread. So
yeah, maybe.
I find Antonella's comment pretty nice because she focused on the complete response rate, which is similar in radiation and some, because with surgery is 100% by definition, but maybe similar with radiation, because this is the only thing we may use as a surrogate of the effectiveness of the local treatment we decide. And of course, the prognosis will not depend on the type of local treatment. If we admit they are equal, rather than the disease behavior during the follow-up.
May I ask Yoti, what do you think about this?
So my thinking was that if they are surgically amenable to completely resect, then perhaps that would be a better choice, especially if we can completely get an R0 from whatever lesions are there. However, if they are borderline resectable or something, perhaps radiation would be definitely an option. That would be my traditional way of thinking. But having said that, I'm open for this thought process also, that perhaps radiation can also do equally good. But also this will depends upon what kind of histology and how much is the sensitivity, radiation sensitivity, etc. So that's what I would say.
Okay, thanks. Then if you have again 2 nodules and but a previous free interval which is much lower, my question is whether you would go for surgery alone again, or would you use chemotherapy? And if so, then would you choose to do surgery only in responsive patients, or in all patients all the same, just because chemotherapy in any case may not be so crucial? I mean, here you have a lower free interval. So what do you do at your institutions? For example, may I ask you, how in this case would you rate the chances of surgery only to be curative with such a low free interval, but just 2 nodules? Joanna, when you see that there are enough votes,
Yes.
and show. Okay. So some of you, feel that the number of nodules is more important, not probably that the free interval. But many of you, lower chances of cure. And okay, Yoti, please.
Yeah, so I feel that because the disease-free interval is pretty low, this is biologically aggressive disease, and that's why chances of getting cured by surgery alone is really dismal. And there is no systemic therapy before, so perhaps the approach may be to start with some kind of systemic therapy, and that will serve as an in vivo drug effectiveness also to test, if it is working, then later on after surgery also we can consolidate. Because if we'll do surgery and there is no chemosensitivity, we'll have nothing to back it up, and there will be fast recurrence. That's what would be my opinion.
And so by doing chemotherapy, this is my next question. By doing chemotherapy, how would you place the probabilities of cure with surgery after a response to chemotherapy? Would this change your estimation? So can we go?
Responding disease, yeah, if it is a responding disease, then I would prefer to go for full-fledged surgery and kind of that. But if it is just not responding, then even if we will remove that, the chances of coming back is very fast. So I would go radical and doing things if it is a chemo-responsive disease, that would be my choice.
And so my question on which I ask you to vote is, would you do surgery in any case, or only in the case of response? So it's just a 1, 2. You see here that from 1 to 5, but you can vote just a 1 or 2. So would you do surgery only in case of response, 2, or surgery in any case, even if the patient doesn't respond, 1? Just 1 minute, we see how people voted. Okay, so people would do surgery only in case of response, basically all of you, because the free interval was very low. So, Antonella?
Yeah, one piece of consideration that are already made. Actually, we have to better define what a response is, because we know that progression might be simple, well, not banal, but just dimensional progression with the number of nodules that is still 2. In this case, considering progressing disease by dimension but not by number, I actually will go to surgery, even if this is not a response.
Okay, so in other, yeah, it's very. I agree with you. I think that, for example, if the disease doesn't respond but doesn't progress
Yeah.
in number,
Yes.
you do surgery in any case. If
Yes,
you see a progression in terms of an increase in number of lesions, you would.
Of course not. But
Yeah.
it's just must be something biological if the disease progresses under chemotherapy, but just dimensionally. So that states that cells are in those nodules are resistant to chemotherapy, but the biology is of a disease that is not going to be widespread. I would go to surgery in that case.
Okay, Salvatore, did you have something to say?
Yeah, actually the same comment covered by
Okay.
Antonella. So I mean, to me, if the disease progress dimensionally, not numerically, it just quite like the opposite as the past situation where the surgery may find other tiny nodules. Like, okay, we have these 2 nodules, they are progressing, so but maybe they are the only 2 nodules, and we can cure the patient by surgery or again any other local treatment like radiation.
It's interesting. Yoti?
Yeah, so I agree with what has been discussed, that if it is only a dimensional progression, at times, when we do surgery and take it out, a lot of that part is necrotic, and the cystic changes, which are actually kind of a response, but dimensionally it is kind of little bit increasing also. So I would do the same approach. If it is only dimensionally increasing and not new lesions, then I would go for surgery and see in the histology what it is actually.
Okay, so there is a consensus that we should distinguish 2 kinds of progression in practice, which is interesting, I think. Okay, then, I mean, would this change something in your selection of chemotherapy? So if it is a synovial sarcoma, which is more responsive to chemotherapy, probably, than an UPS, I mean, would this change something in your selection of chemotherapy? Although I understood that many of you would do chemotherapy, would have done chemotherapy in any case, also in the case of an UPS, so probably this didn't change so much. But how would you rate, for example, the chances of cure of a responsive synovial sarcoma? So you do chemotherapy, you do surgery because the patient responded. How would you place the likelihood of cure in this patient? Do you like to vote? Okay, so in practice, I mean, your feeling is that chemotherapy would have increased the likelihood of cure. I mean, being a responsive patient and being a synovial sarcoma. I mean, this, okay. Any comment, Lorenzo? Do you want to comment?
I just want to raise a point that might be that sometimes challenged us in the past, because with these tiny nodules, especially the left one, is quite tiny. So
Yeah.
the risk, let's say, risk is not the best word, but you can even have a nearly complete response in this tiny nodule, especially with the synovial sarcoma. So my question is, if you have a nearly complete response, would you go to surgery once again or not?
So, yes, this is a very important question. So, would you do surgery even in a complete response one, or wouldn't you do surgery if you don't see anymore the lung nodule two? So one, you do surgery even in the area where you don't see so much. At least you explore your patient and you try to find if you feel something. Or two, you wouldn't do surgery.
Well, I have to say that at least our thoracic surgeons are not really keen on going to surgery if there is no visible lesion at the CAT scan.
Yeah.
That was exactly the point.
Yeah. Okay, although probably people have been quite split on this. Yeah, apparently.
Because, you know, in some way it is a paradox, because you have the best response you can have with chemotherapy, that is complete response, but then you will lose a window for surgery. So it's something that is always tricky.
Yeah, it's true. It's in an uncomfortable situation sometimes. Okay, then you have, okay, 9 months of previous free interval, but you have a lot of nodules. I mean, how many of you would do surgery even if after chemotherapy, after some response to chemotherapy? I mean, with 10 nodules, would you do surgery, assuming that there was that you did chemotherapy, that the patient responded, but the number of nodules was so high in any case? May I ask you, how would you rate the chances of cure of a patient like this with surgery after a response to chemotherapy? Okay, so many of you, half of you would say that there are no chances of cure, while someone says that 10% or even more may still be there. In any case, as I understand, I mean, at least half of you would go for surgery, no? Even if the number of nodules is so high. Any comment on this? Any who wouldn't go for surgery in case of response? Lorenzo?
I think that it is very hard to foresee the possibility to go for surgery in such a situation, especially if you have a response, because you will be in an even complex situation, more complex situation compared to the previous one, because you have small nodules, multiple ones. I think that my thoracic surgeon will not agree to go for surgery in presence of response, or in this case.
Yeah, which could be a little bit paradoxical, no? Because possibly the only patients likely to have some chances are those who responded, no, in a case like this. So
exactly, the problem is that you probably will left behind you some lesions.
okay.
Probably this could be the case in which you factor radiation in.
Yeah, radiation therapy, but
In
the
this case-
number of nodules is very high, so it's
No.
No, if you have responding nodules, some, let's say, disappears, you have
okay.
No.
3, 4, 5 nodules left, small nodules because you had the response. So probably,
It depends of the size of the nodule, because
Yes,
if
of course.
the dimension is less than 1 centimeter, it's very hard to check the nodule during the treatment, not during the CT simulation, but during the treatment, even if you use for the CT and the brief fold. So it depends of the size.
yeah, it depends also on technical issues, yes, of course. So okay, I don't believe that this would change so much. So then let's go to the second relapse. So when you have a second relapse and you have a small number of nodules for an interval of 9 months, I would like to understand how do you rate chances of cure of a patient on a second relapse? I mean, maybe you decide to do chemotherapy and okay, let's think of a responsive patient, for example. This patient underwent chemotherapy, made surgery. How do you feel that its chances of cure would be? Can we vote on this? Okay. So, I mean, you would give some chances of cure definitely to a patient like this. Okay. Any comment on this? I mean, you would. I mean, the concept of repeat surgery, you know, is quite central in surgery of lung metastasis. I mean, do you think it's a strong concept?
I mean, I think it's reasonable, provided the elapsed time, the disease-free interval is good. But I also give a proper value to chemo because I mean, of course, we don't know the role of pseudo-adjuvant chemo in this setting, but in a very optimistic way, in an untreated patient, we may estimate being similar, but probably a bit less than what we would have in a adjuvant setting. So if we assume this case without chemo would have 100% of chance of relapse, of a third relapse, and then we decrease a bit the risk thanks to chemo, in the end, we may achieve something which probably is not 10%, but not too far from 10% of chances of cure.
Yeah, because another option could be to look at not so much cure, but just some benefit in progression-free. But let's go to a third distant relapse. So assuming that there are just 2 nodules, but it's a third relapse. Would this so the same situation, but a third relapse? How much would you rate the probabilities of cure given a response to chemotherapy again? Okay, so still some chances of cure. Any comment on this? I mean, how long would you go for repeat surgery in these cases? I mean, provided the free interval is reasonable, provided the number of nodules is reasonable. So how long in your patients do you go on? Yoti?
So I think there will be multifactorial depending upon the performance status of the patient, depending upon the disease, the previous free interval, depending upon what kind of therapy we have used, and number of nodules, the resectability of nodules. I think all these factors I will take into account and to decide.
But I mean, in a good performance status patient who is in a reasonable prognostic factors, would you go for surgery? Yes.
In a responding patient, I would like to, try best. That's what, for whatever minimal chances of long-term survival, I would like to offer to the patient.
But sorry, my second question is, do you see that, do you see response to chemotherapy as a crucial factor, by which you would operate only patients who are responsive or not?
Yes, I would take chemotherapy response as a very crucial factor because that will decide the prognosis.
Okay, Lorenzo?
Just a quick point. I think that in the end, 9 months of free interval in the third relapse are better than 9 months of free interval at first relapse in some way, if you look at them. So for sure, this patient is hard to be cured, but in a strategy of prolonging disease-free interval might be still considered, I guess. 2 small nodules with a disease in the free interval of 9 months in third line. It's something better than we can expect with the great majority of treatment or medical treatments we have. So something that should be still put on the table.
So my next question is, do you think that in these cases, with some nodules, third relapse and so on, progression-free interval at 1 year, progression-free survival at 1 year is a more reasonable endpoint than cure? So do you think, in other terms, how do you rate the chances of cure of for example, think of doing surgery only because the patient already received chemotherapy? I don't know, you cannot do chemotherapy. You decide to do surgery only. Do you think that a patient with 6 nodules, third relapse, 9 months, do you think that surgery may provide some chances of a progression-free survival higher than 1 year? So you can vote on this. Okay, so even, some chances of cure, chances of progression, so of prolonging the free interval in practice with surgery. So you still view surgery as an important player, in prolonging the progression-free survival, at least. Any comment on this?
Yeah, I think one of the objectives in a case like this may be chemotherapy-free interval for specific patients. So it can be reasonable to offer surgery, trying to achieve a still quite long disease-free interval and chemo-free interval. So it's a typical case in which I would share the decision with the patient, discussing all these issues as well.
So surgery may obtain the same which chemotherapy might obtain. 6 cycles of chemotherapy. Salvatore?
Regarding the case you just showed, I thought that possibly it has not been covered yet is the pattern of metastasis. I mean, we were in a situation of a third recurrence with just 6 nodules. So it's like it's making few metastases and have a very long disease.
I don't hear you. So
Oh, okay. Just a second. Can you hear me better now?
probably yes.
Okay, so my point was regarding the metastatic pattern. We have at the third distant relapse, so it's the third time that this disease recur, and we have just it's almost oligometastatic. Okay, so and there is with just surgery a 9 months of interval, so that's something that maybe it's telling us that the disease is not very quick. Because you made a great deal of saying that so people even after the third relapse still consider surgery, but probably it's because of the case you presented.
Sorry, since you're a pathologist, I mean, do you think that, for example, if you do chemotherapy preoperatively, the pathologic exam of the specimen, of the surgical specimen, may tell us something interesting for our choice? For example, the prognosis, something like that.
In the metastatic setting, I don't know. You know that we have doubts also in the non-metastatic setting.
There are so many problems also with the local response.
The only point probably it's worth mentioning here is that in this particular setting, so in the metastatic one, you are judging the metastasis you removed. So the problem is what is still inside the patient. Your assumption there is that everything that metastasizes is equal, and we know that that's not the case for many tumors.
I mean, sometimes you may make some assumptions. Okay, the next question for you is, are you used to doing something like this? So in some cases, you observe your patient for 2-3 months, and then you decide to do surgery or not, depending on whether there has not been a progression or there has been a progression. So it happens to you to make this kind of reasoning. Do you like to vote? In general, I mean, in these cases, in soft tissue sarcomas. Observe the patient for a while and do we have responses? Okay, so never in 10%, but some of you actually, it happens that you observe the patient for 2-3 months and then decide whether to do surgery and the lack of progression. Any comment about this? Is it easy for you to let your patient understand the rationale about behind this? I mean, doing nothing for metastatic disease for a while.
It's never easy, but explainable. I mean, the reason is what we said earlier about the major sensibility of the techniques we have today rather than the standard chest radiogram we had in the past. So we've been detecting 3 millimeters nodules, which much likely are. But of course, it's very hard to say how many nodules we may have.
Okay, but I mean, aside from the cases in which you are, I mean, you are not sure that patient is metastatic, but aside from this, I mean, when you are sure that the patient is metastatic, but you want to see what is the natural history of the disease.
Yeah, just to select, let's say, if the patient is amenable of surgery or not, because we may rush operating a very tiny nodules without seeing or detecting other microscopic nodules which may rise at the first follow-up after the local treatment. So it's reasonable to wait if, again, the possible progression is just dimensional, and in case go for a local treatment or even numeric, and in that case, depending on what extent, of course, think about a systemic treatment.
Any other comment on this?
I fully agree. I think that in the end, of course, it's not so easy to explain to the patients, but in the end, if you have multiple nodules jumping out in a few months, we usually use a 6 to 8 week interval, I would say, in these cases to rescan the patients. But in the end, if 5 or 6 nodules will appear in such a short time frame, then the patient is not curable. So you have to in some ways try to slow down the disease, but you cannot cure them. So we sometimes use this, especially when we have a short time interval between the diagnosis and metastatic disease and so forth, just to see whether it is worth to go for surgery or not. By instance, one of the first cases you showed is one where we should have considered also this approach, because we have the small nodules, an increase in the dimension of nodules would not prevent surgical resection. So it's something that could be considered.
See, although 6, 8 weeks may also be a waiting list or something like that.
Yeah, that's true.
Yeah, exactly.
The
We try to
usefulness of
rescan
a
the
waiting
patient just
list.
before surgical resection.
Antonella, what do you think?
Yeah, I totally agree. And in my case, I sometimes also consider the histology, because it is more difficult to me not to start any treatment instead of observing for some chemosensitive disease. It is less difficult if you have some nodules in unlikely to respond, in the disease unlikely to respond.
Okay, my last question, clinically speaking, is whether a pleural involvement makes a difference for you. I mean, would you go to surgery? I mean, here the pleural involvement is a little bit heavy, but I mean, is this a factor which you would consider, for example, good prognostic factors, but pleural involvement? I mean, how would you rate the chances of cure of these patients? Would you still give some chances of cure or not? Okay, so some of you, but some of you wouldn't. I mean, some of you would see the pleural involvement as a limiting factor for surgery. Okay. So, I mean, I don't, I wouldn't make other questions, but just a final comment on your side. I mean, I think that most of us try to make decisions on the basis of some factors which are not so much validated. I mean, if you look at published evidence about surgery of lung metastasis, so in any case, the approach to lung metastasis, I mean, you don't find so much. You don't find prospective studies, comparative studies. In the past, when we tried to do comparative studies, we failed. The number of factors to consider is so high, as we saw, the number of lesions, the free interval, the feasibility of surgery, the sensitivity to chemotherapy. So, I mean, what is your impression? I mean, how could we improve our understanding of one of the most typical presentations of adult soft tissue sarcomas in the end? Any comment about?
I think that performing, of course, a randomized trial is not possible in this situation, or at least very, very difficult. But probably this is the case where real-world data, if they are captured prospectively and with a solid data set in the setting of Huracan, might really help. But they must be a prospective study which can be done, capturing all the variables and the PFS data, of course, overall survival data. I don't know if this can be feasible in the context of Huracan, a prospective registry on management of lung metastases in soft tissue sarcomas.
So do you think, I don't know, because I see that Jean-Yves is connected, but with an iPhone, so I don't know in which...
Yes, I see you. I see you, Paolo.
Okay.
Yeah.
So what
And I was voting, but I was voting, by the way.
Okay.
I mean the 10%, 20% cure rate in advanced phase.
Yeah, do you think that, because I mean, people make a lot of reasonment, clinically speaking, about these cases, and makes a lot of decisions based on something which is not that strong, in terms of evidence. So do you think that, for example, a network like Huracan, I mean, with a kind of registries which we are trying desperately to launch this time, do you think it might make sense, for example, to try an application by using this kind of registries, by using artificial intelligence, I don't know, to help our decision making on this?
I definitely think that's a good, that would be a clear way forward. Actually, the major issue is, as we perfectly know, our capacity to merge the existing data sets, but maybe a prospective data set could help us to do that. And that's the way it should be, because we do not have strong data. So the best solution is to get the input of the experts around this network. And this will probably get meaningful information, probably not consensus, but that's not a big problem. So we should aim for that. But as we all know, the issue is more the exchange of data than anything else, because we would all agree to share the data if it was only for ourselves.
Because, I mean, you know that we are trying to exploit registries in very rare cancers, rare sarcomas currently, which makes a lot of sense because clearly it's the first thing to do. But I mean, could we envisage something like that for the future when registries may be more, I mean,
you see
more
that as
advanced at least? So do you think we could think of something like that for surgical tests?
probably yes. You mean in a prospective manner or using
An
tools
observational
like
prospective
yeah.
study on surgery of lung metastasis, also trying to compare the different strategies which centers adopt, as we saw.
That would be typically not a clinical trial, but a real-world evidence study conducted prospectively with some level of approval from the patient, which should differ from one country to another, but basically very feasible in my opinion. And probably using another strategy could be to use the European health data space to favor that, even though this is a long shot.
Any other comment on this?
I think there's no better randomization than differences between physicians and patients' decisions. So
that's provocative, but I can agree.
So I think that exploiting real-world data by artificial intelligence and deep learning may have a sense in this, because we may find clusters of behavior and outcome related to specific partners we may investigate on in trying to improve our sensibility in our decisions. So why not?
Okay. There are not other comments. I mean, it's an hour now, so we can also close. I would like just to thank you, and there were not so many people connected, but I hope we will improve in the future. I mean, you know that we are doing this kind of meetings each first Friday of each month, so people may learn that these events are held regularly now. And our next meeting will be on 7 June at 1 p.m. European time, and it will be a journal club, and we are envisaging, to discuss the IMAGIST study, so the randomized study of 6 versus 3 years as an adjuvant imatinib in patients with localized GIST, which was presented at ESMO Rare Cancers in Lugano. And by the way, Jean-Yves will be presented also at an ESMO virtual round, no?
Yes, that's right. On May 9th with a review, and it will be online afterwards, recorded from May 11.
On May 11, okay. So we
May 9 for live.
Okay, so I think we could have a discussion among European centers on this. I mean, how our practice may change or not, depending on the study. I mean, also always inviting our guests who are always welcome from Asia Pacific, from US, and so on. So this will happen on June the 7th. Okay. Okay. Thank you so much indeed for being here this afternoon.
Thank you.
Good day.
Bye-bye.
Thank you very much.
Thank you. Bye.
Bye, everybody. Bye-bye.